Morning, everyone. So today I'm pleased to introduce one of my favorite teachers that I've had during my post-secondary training. No, I really mean that. One of the most fun experiences I had during my residency was to take an introductory master's course to respiratory physiology taught by Dr. Inman. So for those of you who don't know him, perhaps in the remote sites, Dr. Inman did his undergraduate and master's in exercise physiology at Waterloo, came here to do his PhD in the same subject, along with his MD, but rather than doing a clinical residency, he went on to do postdoctoral research in asthma and airway biology, and he's an accomplished and well-published researcher, but one of the clearest thinkers I've encountered in my training and as a colleague and as a mentor. He is judging a research competition this morning. He was there. He's back here to teach us today, and then he's going back to the research competition at HHS later. So I'm very grateful that he's been agreed to speak to us today. He's going to talk to us today a bit about some of the common tests that we see and what they really mean when evaluating research. So everybody, please enjoy.
Thank you, Marcel. That was very, very kind. Thank you. Right, so I will try and turn. I'll quickly give a very quick lesson. If you're giving a PowerPoint presentation and you want the screen to turn white, press the letter W. If you want to turn black, press the letter B. All right, so I am here. I'm going to talk, like Marcel, I'm going to talk a little bit about sensitivity and specificity of tests and biomarkers. A lot of people are developing biomarkers. A lot of people are using tests. Marcel mentioned I'll talk about some of the tests that we use. I'll probably just talk about one. I'll talk more sort of in general about sensitivity and specificity and what it means. I'm just trying to figure out which mouse I'm with. Oh, there we go. I'm going to make that so it stays on. There we go. Okay. This is lagging quite slowly. Okay, I'm going to go through two scenarios. Let's imagine, I'm also going to move this out of the way. There we go. Okay, imagine you work in a clinic that has recently stocked an inexpensive point of care HIV test. So you can use this test very quickly. A patient comes in, get a little blood sample, and you can do the test. So first time you use it, a 37-year-old male presents with vague upper respiratory symptoms and expresses concerns that he might be HIV positive because he has recently learned that an ex-partner has tested positive. You run the test and it is positive. The patient is obviously very concerned and you refer him to your infectious disease colleague. Later that week, another patient who's received several blood transfusions during a recent surgery comes to the clinic convinced that she got infected with HIV during the procedure. You run the same test and it's negative. Patient's greatly relieved and leaves very happy. Later, you decide that you're going to read the instructions. Might have been a good idea to do that at the beginning, but you do it afterwards. And you want to make sure you did it correctly. And while you're reading them, you find that the sensitivity of the test is 99.7 and the specificity is 98.5. So those seem to you like very high numbers. And you're relieved that A, the first patient was likely HIV positive, and B, the second patient was likely HIV negative. So I want you to think about which number convinced you that the positive test was probably correct. Is it the sensitivity? Is it specificity? And usually when I give this, it's open to comments from the audience. So if anybody wants to jump in and say something, you can do it. Or how many people are not sure? And the second thing you want to worry about, which number convinced you that the negative test was probably correct? So think about that. Do either of those numbers, the sensitivity or the specificity, help you to decide that those test results were correct? And that's going to be a big focus of the presentation today, is can you get that information from the sensitivity and the specificity? So we'll think about that as we go through the rest of the session. All right, sensitivity and specificity of tests and biomarkers. So think about diagnostic tests. Why are diagnostic tests important? So physicians order diagnostic tests all the time. As patients, you've probably had diagnostic tests done on you. Usually there's two different reasons why you're having one of these tests done. First one is you've gone to the physician, you have symptoms, you have something you're complaining about, and the physician orders the test to find out whether what they think you have is what you actually have. So that is important because it allows you to get the right treatment for the condition that you have. Another reason why you might have a diagnostic test would be not because you have any complaints, you feel completely well, but you may be in a population where you're susceptible to a disease. So you'd be having screening tests. So in that case, what you're having a test done to identify a disease that you didn't know you had. And then if you get a positive result, you get earlier treatment for that condition. So I'm now in an age where I am susceptible to GI cancers. So every 5 years, I get to go and have a fairly unpleasant procedure. I have no complaints other than having to have the procedure. But if they find that I have cancer, then I get earlier treatment, and that would be obviously very helpful. So the goal of the session today is to give you some insight into how tests are created, how they're evaluated, and maybe how they're compared to existing tests. And at the end, hopefully, I might be able to go through some thought processes that might give you insight into whether or not you should order a diagnostic test. And the disclaimer is I have never done any research in any of this. This is all stuff I think about. So sensitivity, what does sensitivity mean? So sensitivity means how frequently a test gives a positive result when the condition is present. So if you take all the people who have the condition and you run the test on them, what percentage of them will get a positive test result? Specificity is how frequently the test gives a negative result when the condition is absent. So if you take everybody who doesn't have the condition, run the test on them, what percentage will get a negative result? So it's correct results in two different populations. The practical definition of those depends on whether you're talking about the performance of an assay. So a lot of you guys are basic scientists. You run assays on things, and those assays have sensitivities. So you can talk about the sensitivity in that setting, and you can also talk about the sensitivity when you're talking about a binary classification test, which is kind of what I'm talking about there. So I'll just quickly show you what sensitivity is in an assay. So let's say you've got an ELISA that's useful for measuring VEGF, vasoendothelial growth factor. So if I plot the assayed VEGF, the result I get from the test, against the known concentration of VEGF, I get something that looks vaguely like this. So at very low concentrations of VEGF, the assay isn't picking anything up. Then when it gets to a certain concentration, the assay starts to pick it up. You maybe get a linear relationship, and then at some point, it'll fail to detect further increases. So we call that the upper limit of detection. That's easy to deal with because you just dilute your sample, bring the sample down into this range, and you can measure the concentration. The bottom is less easy to deal with. That's the lower limit of detection. I can't detect VEGF below that concentration. So as a basic scientist, you need to be aware of that lower limit of detection, because when you say it's not there, it doesn't mean it's not there. It means it's not there in that quantity. So that's also referred to as the sensitivity of the assay. How low of a value can it detect? If you're doing this type of work, you'd also need to demonstrate that the assay is specific, that it's not measuring other things when you stick them into the measurement. But I'm going to leave that behind, and we'll talk now about binary classification tests. So you're looking for a screening blood test for prostate cancer. So there's a researcher here just upstairs, Dr. Khalid Al-Nadawi. He came 15 years ago, and he was uber excited because he came into my office. He was super excited because he had a test that he developed that he was convinced always gave a positive test result in a patient with prostate cancer and always gave a negative test in people without prostate cancer. He worked on that for a few years and then he left because I don't think it worked. So a perfect test would mean a positive test result would mean the patient has cancer and needs surgery. You get the test result, they go straight to surgery. Negative test means there's no cancer and no need for surgery. You get the test result, you send them home, tell them you're fine. Obviously, a bad test would mean that a positive result will include many non-cancer patients who may proceed to invasive investigations or even to surgery, which wouldn't be good. And more importantly, a negative test will miss real cancer, who will not have surgery and will not do well. So this is a figure I'm going to use quite a bit during this presentation. So this shows two populations, healthy population and patients with prostate cancer. I'm, in this case, measuring, let's say, a blood-borne protein that is predictive of whether or not you have cancer. And so this is the frequency of test results. So in the healthy population, I've got very few test results down here, lots in the middle, very few test results here. In the cancer population, I've got very few test results here, lots here, and very few here. But the important thing there is there's no overlap. So I can draw a line, I'll call it the criterion line, and decide anybody who gets a protein value higher than that has prostate cancer. Anybody lower than that doesn't. So that's a perfect diagnostic test. It's never going to make a mistake. How many times are there perfect tests, useful perfect tests in clinical practice? Not that I've ever seen. You never have a useful test where you've got no overlap between the two possible groups. And you could come up with one like the heart doesn't beat for 3 months, the patient's dead. But that's not a very useful test because it's fairly obvious. So in reality, this is what you see, that patients with cancer will distribute higher than healthy people without cancer, but there's overlap. So in this case, if I look at the prostate cancer patients, the people above the line that I decide is the criterion line get a positive test result. That tells me they have cancer, and that's a true positive. It's a cancer patient with a positive test result. They're less than that criterion line in the cancer group. They get a negative test result. I don't know that they don't have cancer, so that's a false negative, a negative result for a cancer patient. You look at the healthy people below the criterion, it's a true result. It tells me they don't have cancer, and that's correct. If it's above the line, I don't know they don't have cancer. It's a positive result, but it's a false positive. I'm going to show another example. This was one example where the thing I'm measuring is distributed along a continuum, where both groups have it, but one group has it to a higher extent. This is probably a more common type of test result. So this is where one group does not have the thing they're looking for. The other group does have it, and it's distributed over a range. So an example of that would be the NAT test to measure COVID. So in this case, you get a PCR reading where you have a wide distribution of positive results in the patients who are infected with SARS-CoV-2. But some of those patients will have a level that's below the limit of detection. So they're infected, but you can't measure it. So those patients will get a false negative. So false negatives occur for patients with a viral RNA below the limit of detection. Would you get false positives here? So nobody who's not infected with SARS-CoV-2 will have the thing you're trying to measure. Would you get false positives? Yes. So you can get false positives. Why do they occur? So at the beginning, they thought you might have cross-reactivity with other coronaviruses. That turned out to not, I don't think that happened very often, but there were still false positives. So where did they come from? There's a guy up in the Yukon territories. He showed up, I think he had a cold, got tested, it was sent down to the testing center, and it came back positive. He didn't have SARS-CoV-2 infection. How'd that happen? Any number of reasons. You could have the sample could be mislabeled, could be read in the wrong order on the machine, could have been read right after another patient who had a very strong positive and there was contamination. So there are any number of reasons why you could get a false positive, and any cause of a false positive would be a feature of the test performance. Because when you, the physician, gets the test result back, you have no idea how it went wrong. All you know is that it came back and told you this patient is SARS-CoV-2 positive. So it's a positive test result. It's not a failure of the test, it's a failure of the whole system, but it's still a false positive. All right, so that's what we'll talk about. These sort of ways in which you can get false positives, false negatives. I'm not going to differentiate between that type of a test and that type of a test. I'll use this one as an illustration because it's much easier to point to, but it could work just as well for that one. So there's your test. There's the two populations. What are the properties of these tests that can be used to evaluate whether it's a useful test or whether it's good, better than another test? So we've already talked about sensitivity and specificity, but there's more properties than that. And I think I alluded earlier on that when you've done a test, simply knowing the sensitivity and the specificity to interpret that test result is not enough. So sensitivity is the likelihood that a person with the condition will have a positive test. Take all the people with the condition, what percentage of them get a positive test result? Specificity, the likelihood that a person without the condition will have a negative test. Take all the people all the people without the condition, how many of them get a negative test result? These are the other features of the test that I sort of alluded to before. So this is positive predictive value. So the positive predictive value is the likelihood that a person with a positive test has the condition. The negative predictive value is the likelihood that a person with a negative test does not have the condition. And this is where people get confused, even if they've looked at this many, many times. Looking at that definition, the likelihood that a person with the positive test has the condition sounds an awful lot like the likelihood that a person with the condition will have a positive test. You can easily think that that's saying the same thing. It's not. Anybody want to raise their hand who gets confused with that? I'll tell the people at home that everybody here put their hand up, but they didn't really. All right, we'll go through this to try and illustrate how those two sets of numbers are profoundly different. So here's the figure again. What I've done down here is created a 2x2 diagram. So now I've got the positive and negative test results. And here I've got the presence and absence of the disease. And I'll put letters in to illustrate each of those compartments. So the sensitivity. Sensitivity, want to find out how many people who have the disease get a positive test result. So the population we're interested in here are the people with the disease. What percentage of them get a positive test result? So that's A out of A plus C. I'm always hugely relieved when I get that right. See the right letter up there. Specificity, we're interested in this population, the people without the disease. What percentage of them get a negative test result? So that would be D out of B plus D. Now we're going to look at something completely different. Now we're looking at test results. So if you look at the positive test results, how many of them come from a patient with the disease? So that would be A out of A plus B. And now negative test result, if you're a doctor, you've ordered a test, you've got a negative test result, what percentage of the time does a negative test result come from a patient without the disease? So that's D out of C plus D. So if you're ordering a test for the hospital, you get all these sales reps coming with their different tests, you want to pick the test with the highest sensitivity and the highest specificity. So you'll see how much money you have. If you're really interested in getting good sensitivity, you'll find a test with excellent sensitivity, you'll probably pick the one that also has the highest specificity that you can still afford. But if you're a physician and you've ordered the test and you get the test result back and it's positive, do you care at all about the sensitivity of the machine? No, you don't care at all about that. It doesn't tell you anything. What you care about is how likely it is that the patient has the disease. So of all the positive test results collected in this center, what percentage of them have the disease? So if you get the test result back and you say it's positive, I'm pretty sure you have the disease because the sensitivity of the machine is really high. That's a waste of time. All you've done is told the patient, if the patient has any mathematical knowledge, that you don't know what you're talking about. So you need to be aware of the positive and negative predictive values when you're giving the information back to the patient. All right. So there they are again. Are these properties fixed? So for a test that you order on a patient, are these properties fixed? And most of you who are clinically active probably aware that the positive and negative predictive values change widely depending on the population you're using it in. We'll come back to that, but you can imagine if you're using the test in a population where a lot of people have the disease, then you have the pre-test probability is high. A lot of the people have the disease. In that scenario, positive predictive value is going to be very different than in a scenario where very few people have the disease. So we'll come back and we'll talk about that later. But sensitivity and specificity, are those properties of a test fixed? So here at the I'll remind you again of what sensitivity is. There's the population of people with the disease. There's their distribution of test results. In this figure, I think maybe 80% of the population will have a positive test result. 20% will have a negative test result. So in that case, the sensitivity is 80%. Is that a fixed property of the test? You'll always read in textbook that it is. Sensitivity and specificity of tests are fixed properties. Is that true? Could I do anything to change the sensitivity of this test? And you're all thinking through, and some of you are thinking no, some of you are thinking yes. I can change the sensitivity of the test. What I can do is move that criterion value. I can move it to the right. That makes the test less sensitive. I'm picking up a smaller percentage of the patient with prostate cancer. The advantage of doing that is I'm picking up fewer of the healthy patients without prostate cancer. I could also move it the other way, make the test more sensitive. I'm now picking up a larger percentage of patients with the condition, but I'm now picking up more of the patients without the condition. So when we purchase a test, that usually comes with a set criterion value. So the test has a sort of published sensitivity and specificity. But the people who developed that test got to decide where they put that cutoff value. So I'll go through how that might be done. So imagine you are a research fellow or undergrad or grad student, and you went to work with Dr. Al-Madawi, who wanted to evaluate his test for prostate cancer. How would you develop that test? So the first thing you need to do is measure his protein in all the healthy and a group of healthy and a group of diseased patients. So you need to, first of all, you need to find those two populations, people without prostate cancer and people with prostate cancer. I think when you're doing that type of research, finding the patients with prostate cancer is a lot easier than finding the healthy people without prostate cancer, because you'd want to have people in the same age range, the same risk profile. And if you just randomly selected a group of people who are of the same age range and same risk profile as your patients who you found with prostate cancer, a lot of those alleged healthy people will actually have a very early prostate cancer. So when you're doing this type of research, you need to very carefully characterize this group for sure, to make sure that you don't have prostate cancer patients in your healthy population. So when you've done that, you're convinced you've got two distinct populations, diseased and healthy, then you simply run your test in all of them, and you get this distribution of test results in the two populations. Then what you can do is you can see how well the test works as I change the criterion value. So if I start with the criterion value extremely high, higher than any patient's measurement, then I would have a test with 100% specificity. It's giving a negative test result to every healthy person. Great, but it's useless because it's got zero sensitivity. It's not picking up any prostate cancer patient. As I move the criterion value down, I start to pick up prostate cancer patients before I pick up any healthy patient. So sensitivity will increase while specificity stays at 100. As I move it down further, then eventually I reach 100% sensitivity. I've got all the prostate cancer patients, but by that point, I've picked up quite a few healthy people. So I've now got a drop in specificity. And if you move it further down, you complete the two curves. So now you've got all the information you need to decide where I'm going to stick that criterion value. So, and then I'm going to market the test or test it in a population. So where would you decide? So you're working in this lab. This is your job to develop the test, and now you're going to run clinical trials with your test. You have to pick where to set it. Where would you pick to set it? And the answer that I usually get is you stick it right here, where the sensitivity and the specificity are both as high as they can get without decreasing the other one. Would that be a good idea? It really depends on where you're using the test. So let's say this was a screening test, a pap smear, evaluation of the cells taken on a pap smear, or evaluation of biopsies taken in a biopsy in a colonoscopy. Where, as a patient, would you like that criterion value to be set? You don't want it to miss you if you've got the disease. So you're going to set it here, where the sensitivity is close to 100%. So that means everybody who has the condition gets picked up. Disadvantage with that is that you're picking up a lot of non-diseased patients. Does that matter? For screening tests, matters a bit because you're going to have people who are very anxious with a positive test result, but you're going to bring them back, and you'll then do a much more invasive, much more expensive test that will then sort out the patients that you've selected with your screening test into the true positives and the false positives. So for a screening test, you always want to have one with the highest sensitivity. For a more sort of further down the road test, you also want to have one with high specificity. So you're not going to end up doing surgery on patients who don't have the condition. So deciding where to put your criterion value really depends on where you're using the test. So here's an illustration. This is a test that we do actually use here. So methacholine PC20, a lot of you came to the conference on the weekend talking about airway hyperresponsiveness. So we use methacholine to get a value called PC20, which decides whether a patient has airway hyperresponsiveness or not. The range of PC20s is huge. It goes from 0.003 up to 256. Somebody had to decide at what point on that continuum do we say that somebody is hyperresponsive. It's like a yes, no decision. You could put that anywhere you want. There's no biology that tells you a patient's hyperresponsive. It's this test, and we can put it anywhere we want. So Don Cockcroft, who was here, spent a lot of time thinking about that. Here's one of his later studies. This was where he took close to 500 university students and sorted them into patients with current asthma and people without asthma. And he looked at what happened when he changed the PC20 that is the decision for hyperresponsiveness, yes or no. So if you made it 1, anybody with a PC20 1 or less, then the sensitivity was terrible. it only would define about 45% of the asthmatics as having airway hyperresponsiveness. As he moved the sensitivity to a less responsive point, then he picked up more of the asthmatics. So he made it at 2, it was about 50%, 4, it was about 60%, 8, he picked up 100% of the asthmatics. So that's what, based on this paper and a lot of other papers and a lot of other people, they decided, we'll say that airway hyperresponsiveness is defined as a PC20 8 or less, or some people say 16 or less. The advantage of that, it doesn't really, it doesn't tell you that they have hyperresponsiveness because it's an arbitrary decision. The advantage of that is that picked up 100% of the asthmatics. But in this population, it also picked up a lot of healthy people. So the positive predictive value at that point is very low, because if everybody who had a PC20 of 8 or less was labeled as asthma, you're picking up tons of healthy people from this population. If you moved it down to 1, then the positive predictive value is huge. All the positive results are coming from asthmatics. The trouble is you're missing tons of asthmatics. So the point here is the criterion value is picked at a point to be practically useful. If you don't have a PC20 less than 8, then you likely don't have asthma. So when you order the test on a patient who you think has asthma, if their PC20 is not 8 or less, they likely don't have asthma. The opposite is not true. If you have a PC20 less 8 or less, it's incorrect to say you do have asthma. So it's a test that is more ruling out. If they don't have airway hyperresponsiveness as defined by a PC20 less than 8, it's not likely that they have asthma. But no test result will tell you that it's likely that they do have asthma, especially in the population here in the clinic where many other patients have hyperresponsiveness due to other reasons. All right. So that's an example of where the demarcation point between yes and no was decided for a very specific reason. Okay, one of the problems is the fact that I can manipulate the sensitivity and specificity of a test can make it a bit difficult to evaluate 2 tests. So let's say the hospital already had a test for diagnosing cancer. There's an established test, and somebody came up with another one with a different sensitivity and specificity profile, and they now want to sell that new test to the hospital. So there's the existing test. There's the proportion of test results in diseased and healthy people. Somebody came up with a new test, which they want to sell to the hospital, which has a different profile, and you can see it's not as good. There's way more overlap between the diseased and healthy people. But the people who made that test can make them look equally sensitive. So they can set their criterion value here. The test has exactly the same sensitivity as the existing test. It's not inferior in terms of being able to decide that a diseased patient gets a positive test result. They're both the same. Trouble is that it's way less specific. It's picking up a lot of healthy people as being positive. Or they could make them look equally specific. Move the criterion value over here, pick up the same percentage of healthy people. So how do you compare these 2 tests to decide which one is best? The hospital wants to know, I'm going to buy this test because it's got a better sensitivity specificity profile. So they could try and get this data and compare what's the overlap between the 2 curves. Some of you will probably know that there's a very long science behind how you do that, how you compare the performance of 2 tests. So I will quickly go through that because people often ask what this means. So when you're comparing 2 tests, you compare them using something called the receiver operator characteristics curve. This is where you plot true positives against false positives as the criterion values change. When I read that first time, that meant absolutely nothing to me. I thought, what the hell do those words mean? Then you look at the figure. So there's the figure, true positives against false positives. Again, I'm not sure what that means. So the way I figured out in my head was to sort of work through it. So what I'm going to do is I'm going to go through 3 different tests, plot them on here, and then hopefully it'll make sense. So this is a useless test for diagnosing prostate cancer. So a really useless test would be height. Everybody taller than 8 feet has prostate cancer. That would not distinguish at all between healthy and prostate cancer patients. But I can see what happens. If I start by saying everybody taller than 8 feet has prostate cancer, I don't pick up anybody. I don't pick any prostate cancer patients or healthy patients. So I've got 0 positives, no true positives, no false positives. So I got a point down there. As I move the height criterion lower, down to maybe 7 feet, I start to pick up people from both populations, but in equal proportions. So I've picked up just as many prostate cancer, just the same percentage in the prostate cancer population as the healthy population. So now I get a value there. Pick them up in the same proportions. As I move it further down, same thing happens. I get the proportional equivalent from both groups. So you end up with a line as you move the criterion value through the full range along there. So that's the line of uselessness. If you have a test, do this, stick a curve on here, that tells you the test is useless. If I now do a perfect test, do the same thing. Start with the test value high positive. I'm not picking anybody up, so I've got a value down there. As I move the criterion value down now, I'm only picking up prostate cancer patients. So I'm only getting true positives. So I get all the way up to the top. I've picked up all the prostate cancer, all of them have been given a positive, which is a true positive, before I've got any positive results from the healthy population. But if I keep moving it down, I'll eventually pick them up. So I get values across the top. So if I plotted a perfect test on this curve, I would get a line that looks like that. So that defines a perfect test. If I then look at a real test, do the same thing, start with it too high, I get no false positives, no true positives. And as I move it down, I will pick up more disease patients than healthy patients. I'll get proportionally more true positives. So I'll end up filling up the curve like that. So that curve describes that test in the full range of sensitivities and specificities. So as a decision maker, and whether you're ordering the test, you don't need to think about what sensitivity you want. This describes the full range of the test. There's ways to analyze that. You can, if you're buying a new test, you look at the 2 curves. You can compare them based on the area under the curve. You compare them on something called the Uden index, which is the farthest each test gets from the line of uselessness, if that's what it means. So those are means of comparing 2 tests. So I think that's sometimes used in deciding whether to buy a new test or not. I think usually what happens is you would decide whether the test has the sensitivity that you need. And when you're achieving that, what specificity do you have? And is that something you can live with? Where's that name come from? Receiver operator characteristics. It's largely as a result of Pearl Harbor. So the US Navy was taken completely by surprise when Pearl Harbor was bombed. So they decided to put in a lot more radar detectors, and they wanted to make sure that the radar operators were good. So the radar operators were called receiver operators. So each person working on a radar had their own curve that describes how well they could differentiate between incoming planes and mistakes, flocks of birds. So each receiver operator had their own receiver operator characteristics curve. And then that was the same statistical mathematical approach was adopted when comparing sensitivity and specificity of drugs, but they didn't get rid of the name. So the name refers to radar operators there. The second important thing you learned today. All right, I said I would talk about the impact of disease prevalence on the predictive values. So we can look at the same test in 2 different settings. The test we'll look at has 90% sensitivity and 90% specificity. And we'll look at in the settings where the prevalence of the disease is 10%, and the setting where the prevalence of the disease is 90%. So the first one, where it's 10%, I picked an example. This is not a test. I don't know of a test to diagnose asthma, but I picked asthma as the disease. So in the population at Wild, probably somewhere close to 10% of patients have asthma or might have asthma. 90% don't. So if I use the test in the whole population, 10% of the people have asthma. The test has 90% sensitivity, so the test will pick up 9 of them. 90% of people don't have asthma, has 90% specificity, so the test will only pick up 9 of them. So in that setting, the sensitivity is 90, the specificity is 90, the positive predictive value, that's how many of the positive test results come from patients with asthma, is pretty poor. Even though the test works very well, because there's so few people with asthma compared to the people without asthma, and the test is picking up 10% of the people without asthma, then the positive predictive value is only 50%. It's not good at diagnosing asthma selectively in that population. The negative predictive value, whoa, did that? Oh yeah, the negative predictive is huge. Most people in that setting don't have asthma. Most of those people will get a negative test result. So the negative predictive value is very high. Now we'll move into a different setting where 90% of the people do have the condition. So in that condition, I've changed the proportions. Most of the people have asthma. The test is behaving exactly the same way. It's still picking up 90% of these and not picking up 90% of these. But in that case, because the numbers have changed, the positive test result is almost always coming from a patient with asthma. So in that setting, the positive predictive value is 99%. So what's changed there is you're looking at a population with a high pre-test probability of having the disease. And in this case, the negative predictive value is not very helpful. Half of them will, half of them won't. But what's helpful to you as a physician is you've still picked up 90% of the people with the condition, but you have missed 10 of them without. All right. So summary to there is when you're interpreting a test, you need to know the positive and negative predictive values for the population that the patient is from. They're not fixed properties of the test. So back when you were doing that HIV diagnostic test, you needed to know the positive predictive value of that test in patients who are HIV positive and HIV negative, so that you could interpret the positive and negative predictive value, so you could interpret those test results properly, because only knowing sensitivity and specificity is useless. All right, how do you decide whether to use a test? I don't know if this is going to be helpful. So a good approach is to determine whether a test will change your mind. So let's say you're 90% sure that a patient has appendicitis based on the signs and history that they present with. So they presented signs, symptoms, they got pain at the right point. They've lost their appetite. You're fairly convinced they have appendicitis. They need to go to surgery. And based on your feeling, or maybe a very careful review of the literature, you're 90% sure that they have appendicitis. Patients who present like this will have appendicitis that needs surgery 90% of the time. You have access to another test, maybe an ultrasound test, that will help you with that decision. The test has a sensitivity of 90% and a specificity of 90%, which seems pretty good. So you're 90% sure. You think, well, I'm going to order this test, and that will really help me to be more sure. So if you did that, if you got a positive test, the probability of them having the condition will increase to 99%. The math behind that is exactly what we just did on the last few slides. Based on this, with a negative test, the probability will decrease to 50%. And there's the math. But if you wanted to work through that in your head, go back to those last two slides where we had the numbers in the A, B, C, D cell, go through and calculate the sensitivity and specificity and the negative and positive predictive, that's what you'll get. So, was ordering the test a good idea? Before the test, you consider the patient to be part of a population where 90% of those patients had the condition, and you weren't sure whether to proceed to exploratory surgery. After the test would divide you into two groups of patients. 90 patients who you do the test on will get a positive test result, and now you're 99% they have the condition, and they definitely need surgery. The other 10 patients who get a negative test result, you're now 50% sure they have the condition. So if as a surgeon you're saying it's 50-50 whether they have appendicitis, I'm going to do exploratory surgery anyway to find out, then the test was completely pointless. There was no point in ordering that test. Positive test result is just going to make you more sure. A negative test result is not going to convince you that they don't have the condition. So what kind of test would you need to change your mind? So let's say you're 90% sure they have the condition. There's a test available to you. What would the properties of that test need to be for you to decide to order the test? Would you want to have higher sensitivity or higher specificity? I heard somebody say sensitivity. Absolutely. I'm going to very quickly go here. So this is a calculator which I made. So if you type in your pre-test probability for the condition, what your feeling is about whether or not they have the condition, then you can type in the properties of the tests that are available to you. It will then tell you what the post-test probability is with a positive test and with a negative test. So this tells you, if I'm 90% sure, I have a test with 90% sensitivity and 90% specificity, positive test result, I'm 99% sure. Negative test result, I'm 50% sure. So you can play around with it. So you could say, if I had access to a test with 99% specificity, would that change my mind? No, it wouldn't. A positive test result then would make you pretty close to 100% sure, but a negative test would still leave you, I don't know. What you want is a test that is going to be positive in pretty well every patient with the condition. Then you're not going to miss anybody. So if you had access to that test with 99% sensitivity, that would change your mind. A negative test result there would give you a high probability that they don't have the disease. So I think that's where I will end. And I'm happy to answer any questions that I can answer.
Thank you very much. I appreciate that. This is something we deal with all the time on the inpatient wards. We do tests. Pleural disease is a common one. I don't know if you came across this. In the past, people have these cutoffs for markers from the pleural fluid, and inevitably they're close to the cutoff. They're very close to the criterion line.
Right.
And then trying to decide what it means and communicate it to the patient and figure out what to do is very challenging.
Yeah. And that's where you probably maybe want a second test you can order, but often you don't have that.
I have a question for myself, which is that who does that interpretation? Is it you or the lab? Do you feed that information to the lab and get them to do it, or do you? Which of those would be best?
So for this particular test, or group of tests, a bunch of different things are sent, and there are ROC curves for them, and there are these cutoffs that were published from ages ago from a case series that may not represent our population. The lab doesn't have any of that clinical information, so it's up to the clinician to try to communicate it, and then there can be differences of opinion, and that can create problems. There are some tests where the lab is now what I've seen in more recent years is the lab for some tests, if it's close to the criterion point, there will be a disclaimer. And those disclaimers make people very uncomfortable, but I think it reinforces that people need to look at their population and think about pretest probability.
Right, that's what I was gonna ask, is in those settings, presumably there's a different pretest probability for different patients.
Absolutely, and the difficulty is that tests are often used in a shotgun approach.
Right.
So if somebody has a symptom, they think of all the tests they could possibly do, and they fire them off, and some percentage are positive, and then they decide that that's going to change their diagnosis, the way they manage the patient. This happens in interstitial lung disease very much with positive ANA. Is a common one. 5% of the general population has a positive ANA. Some larger percentage of people with ILD have a positive ANA, and then how to decide which patients need immune suppression, which ones don't. That's all on the clinician.
Yeah, that's why it's important to decide whether you're using tests as screening or to help you with a differential diagnosis, because the proportion of positive and negative test results is hugely different between those two populations.
So I know there's also some frustration sometimes when the lab won't do the test. The lab is making the call about whether you use that test.
It's an interesting point. The example that comes to mind is that in screening for pulmonary embolism, the D-dimer is a test that gets used to decide. It's a sensitive test. So if somebody has a low probability, then they do the D-dimer and it's fine, then you may not need to do the CT to rule out PE. The problem again with that approach is it doesn't take into account the pretest probability.
Yep.
So we have occasional patients with a very high pretest probability. They shouldn't be doing the D-dimer in the first place because it's not, even though it's very sensitive, it's still not sensitive enough.
Right.
So you have your criterion line, but then if it's a very high prevalence population or very low prevalence population, it becomes harder to interpret.
It's not sensitive enough to convince you that they don't have the condition.
Exactly.
Yeah.
All right. Are we able to check whether there's any questions from?
Any questions from the site? No. Okay, I have a semi-related question. So in what situations would we be looking at ROC curves, and in what situations should we be looking at likelihood ratios?
Likelihood ratios. So likelihood ratio and the ROC curves, they kind of describe the same thing, which is the sensitivity specificity profile of the test. When you look at the ROC curve, I don't know how likelihood ratio is nice, and it's a number that you can take and multiply in your head by your own pretest probability and come up with a post-test probability, which is very mathematical. But I'm not sure you could do the same sort of thing with an ROC curve. So I would, if I had a choice, they're showing the same thing, but a likelihood ratio would be sort of immediately useful in your head. If that makes any sense.
All right, terrific. Well, thank you very much for speaking to us today. That was a terrific talk.
Thank you.